Well, good morning, everybody. I'm Arjun Takhar. I'm one of the surgeons at Southampton General. Good to see Neil here, and thank you to the Planets team for inviting me to give a talk. My story started because about 10 years ago, I rang up Neil and said that I was due to go to a fellowship in Australia, and that had fallen through because the hospital in Brisbane had run out of money to pay me. And one of my colleagues, one of my senior colleagues, said that I should speak to Neil because Neil was doing the things I wanted to learn as the extra icing on the cake, which was doing operations on liver via the keyhole. And so I rang up Neil and came down to see him, and I started as a fellow in January 2012, and I haven't really left Southampton since. So my plan was to go back to Birmingham, which is where I trained, and be a liver transplant and liver and pancreatic surgeon, but actually I never did go back. And I think it was the best decision I ever made. And that's purely down to Neil. So I'm one of the consultants. Interestingly, one of my junior sort of trainees asked me how long I'd been working in Southampton for, and I said, oh, it's okay, I'm one of the young ones. And so when he said, well, so when did you start? And I said, 2012, 2013. And he said, oh, you've been there for 9 years, which is quite crazy when you think about it, that time does fly by. And one of the reasons, I'm one of the neuroendocrine surgeons is because when I started to work with Neil, this was one of his big interests. Thankfully, but Tom Armstrong, who's one of my other colleagues, who some of you will know, Tom and I were both fellows of Neil's, and now we are hoping, trying to do as well as what he did for neuroendocrine tumors. So I'm going to talk to you about neuroendocrine tumors. I'm going to give you a bit of sort of definitions. I'm going to talk to you about where you find these tumors. I'm going to talk to you about what they are, because the concept of what neuroendocrine tumors is sometimes very difficult to explain to patients, because frequently people get told they have a cancer, and a lot of times when people get diagnosed, the tumor has metastasized. It's moved on from the actual organ that it started from. And obviously that concept, when you think about, in inverted commas, regular cancer, people think that, oh my goodness, that this means that I'm probably not going to live for very long. And then trying to convince people that that is not the case for most neuroendocrine tumors is difficult, and trying to get them to understand that we don't really offer the concept of cure, because that's the other thing about cancer. People get very anxious about being told that I've been cured or I haven't been cured. While with neuroendocrine tumors, we sort of teach people to live with their disease for many, many years. So a good example is I've just spoken to a gentleman that Neil's operated on, my colleague Matt Hayes has operated on, I've operated on, who's had his initial diagnosis 16 years ago. They still have some disease, but we would expect them to go on for quite a bit longer and have a good quality of life. So trying to explain that concept in quite a lot of neuroendocrine disease tends to be quite difficult. And it is, as a patient, quite hard to get your head around. So we'll talk a little bit about that. We'll talk a bit about functioning and non-functioning NETs, so the so-called carcinoid syndrome, and why people for many years think that they've had hot flushes and there's something wrong with their hormones and they haven't really been diagnosed. We'll talk a little about general symptoms and risk factors, how we diagnose and how we treat people. And in all honesty, one of the things that sort of patients tend to ask us is, well, do you have a set plan of how you deal with? And I suspect Neil used to tell people that he used to make it all up. And the truth is we do make it up, don't we? Because we have lots of options that we can choose from, but there isn't a right answer. And this is, again, a thing that I was sort of trying to explain to a patient in clinic not that long ago, that you go and speak to neuroendocrine specialists across the country, and the sequence of treatments, the type of treatments will be different in each center that you go to. And that is almost the boon and the curse of NETs, where people sometimes feel that they're not getting the best treatment, but actually they are getting the right treatment, and that's what matters. And it is all individual, so there isn't, again, the sort of comparing that I had this and so had that is quite difficult, because every single patient's treatment is tailored to their particular circumstance. So just very quickly talking about NETs, well, these are a group of tumors that arise from these very special cells called neuroendocrine cells, which in fact are found all over the body. But specifically, what I deal with and what Neil used to deal with are the gastroenteropancreatic, and what I'm trying to say is the abdominal NETs. So these are the neuroendocrine tumors that arise below the diaphragm and within the abdomen. So tumors that can affect your pancreas, any part of the gut, so stomach, the midgut, which is the small bowel, and the hindgut, which is the large bowel. But you also get a large selection of these tumors occurring in the lungs. So those are called the bronchopulmonary NETs. And in fact, Judith Cave deals with those, but we mainly deal with the abdominal ones. And actually, most of what we will talk about today is to do with abdominal neuroendocrine tumors. They were originally called carcinoid, which was because they were thought to be cancer-like. And again, I think lots of people in this room and lots of the clinicians treating people would have had that conversation. So, have I got a cancer or not? And I still use the definition that Neil used and does use, I suspect, that it is a cancer, but it is a cancer that works very differently compared to standard cancer. And Neil used to say it's cancer in slow motion, and that's sort of what I say. So these are very slow-growing tumors that the effects of which and the diagnosis of which is made over many years because they're slow growing, they tend to not cause any symptoms. So good example, if you've got a fast growing standard, again, inverted commas, standard cancer in the bowel, most people will find out about that relatively quickly because they'll have a change in their bowel habit, they'll have blood in their poo, or they'll have an obstruction. With neuroendocrine disease, that doesn't quite happen because these tumors literally grow over months and years. There are some patients that we are treating who I'm sure, when we talk about their symptoms, have had them for 20 years or more. And actually, they get diagnosed because of some other reason. So they're having scans for some other symptom and are then found to have a neuroendocrine tumor. So it is a different concept, but it is a cancer because a cancer effectively is a cell in the human body that grows differently in an aberrant manner. So we do tell people, yes, it is cancer, but it's not cancer as you know it. Now, so the other thing that happens is that there are these patients who potentially have this thing called carcinoid syndrome, which a few of you in the room will have, and are getting injections to help control that. So that took a while for scientists and clinicians to put together that these slow-growing tumors were actually producing hormones, proteins that can cause effects within your body. And in all honesty, these have been described for a very long time, but we've started becoming good at working them out, mainly in the last 15 to 20 years, really. So NETs are sort of classified, like I said, according to where they are, and they can be up in the chest, so the BP or bronchopulmonary NETs, and what we are sort of dealing with mainly are the are the abdominal NETs, or what are called the JEP NETs, so the gastroenteropancreatic ones, and like I said, they can arise from pretty much anywhere in the gut. Also, you can have less common NETs. The truth is NETs can be found pretty much anywhere, so along the adrenal glands, along the thyroids. These are the rare syndromes, which are genetic syndromes called the MEN syndrome, so the multiple endocrine neoplasia syndromes. And again, we have a number of patients that we treat across our patch with these conditions. NETs are graded sort of differently, and again, it's something that we get asked about, like, is this an aggressive tumor, is this not an aggressive tumor? And I think for patients, what you need to think about is what sort of, we grade them as grades 1, 2, and 3. The truth is most NETs are what we call a well-differentiated, and what that means is that the tumor's grade is lower, it's a slower growing tumor, it's not going completely crazy. You can actually tell when you look under the microscope that the cells are quite well defined, so that's the well-differentiated bit that you hear about. And quite a lot of our NETs that are diagnosed tend to be in the grade 1 and 2 type of category, and this is, like I said, tend to be the slow-growing tumors. they have, mostly these will be well defined, but also because of the slow-growing nature of these tumors quite frequently will have already moved on from their actual original organ. So it isn't unusual to find someone who has, say, a small bowel net, but actually the diagnosis was made because someone was doing a scan on their gallbladder because they thought they had gallstones and they had liver disease. And the liver disease was secondary tumors which had originated from the small bowel. So that's a very common scenario, that the secondary cancers have already developed because these are very slow growing and have little symptoms that, that patients would go to see their doctors about. So generally, we tend to talk about grades, and most of our tumors tend to be grades 1 and 2. Okay, so there's all sorts. So nets, as you know, 80% of them are what we call our functional nets, and 20% of them are nets that don't do anything. And when we say functional, is that these tumors are producing substances that can, mainly hormones, that can cause patients to have symptoms. And so for example, so the pancreas is the source or the site that makes insulin. It's the neuroendocrine cells in the pancreas that make the insulin. So you can actually have a tumor off those particular cells. So this is something called an insulinoma. That's a type of neuroendocrine tumor. And what that does is there's excessive amounts of insulin in that patient's body. They tend to keep getting what we call attacks of hypoglycemia. So they keep collapsing because the insulin is using up all the glucose, and then these patients really can't function. So you get nets that do that. You get nets that basically can make all sorts of things. So you get something called a pheochromocytoma, which makes adrenaline, will cause patients to have high blood pressure, and all of the hormones that you can think of. So excessive acid production, that's a hormone called gastrin. Again, it's a neuroendocrine tumor, something called a gastrinoma. So these patients get intractable ulceration in their stomach and duodenum, and again, it's a form of neuroendocrine tumor. So 80% of these tumors tend to be functional, and most of these are the type that we find in the small or the large bowel or around the pancreas, and you can get symptoms from that. And patients will typically describe this thing called the carcinoid syndrome, which effectively you eat something which can trigger a release of any types of hormones, and patients will typically say that they get this hot flushing, crampy abdominal pain. Sometimes they get diarrhea, and some patients really have quite severe syndromes. So you can see these patients in clinic, and not quite glowing, but they will be getting a flush when they are sort of talking to you, etc. Those of you who do get that will be on these somatostatin analog injections, so long-acting octreotide, lanreotide, etc. So the vast majority of nets will not cause any problems at all. So in fact, I'll show you my next slide, I think. Most prominent symptoms tend to be abdominal pain and change in bowel habit, so it could be anything. Lots of patients, possibly quite a few patients in this room, have been labeled as having irritable bowel syndrome for many years. Okay, so my bowels have never been right, my tummy's never been right. I've been going to see the doctor repeatedly for considerable length of time, and actually the penny drops when a scan happens, and you can see exactly why the patient's been getting that symptom. So in fact, where's my slide? Okay, so that's the bronchopulmonary nets, which we won't really talk about, but these are patients that get wheezing, chest pain, shortness of breath, etc. Okay, well, let's talk about it. So I will bring up a slide, but the average time between having a net and getting a diagnosis is 9 to 9.5 years. Okay, and that's because the symptoms are non-specific, because it's very hard to put a finger on it. It's very hard to say to a patient that you need a scan immediately, because the symptoms tend to be vague and non-specific. So how do we go around finding out that patients have nets? Well, mostly, lots of patients come to us because they've had a scan for something entirely different. So a good example is I'm about to see someone in my clinic next week who was actually getting a scan for something called diverticular disease, very common condition, and probably needs to have a bit of their bowel removed. But actually, the chap who was reporting the scan said, well, they have got diverticular disease, but if you look at the pancreas, there's a good 3.5 centimeter neuroendocrine tumor sitting there. So they have no symptoms at all, but obviously they need to be investigated, and now they're going through that whole cycle. So quite a lot of our patients will come what we call as an incidental diagnosis. We then also get patients who've been getting syndrome, so the carcinoid syndrome, for many years, where eventually someone does the appropriate tests of testing for the levels of these things called sort of chromogranins A and B in their bloodstream, and finds that these are extremely high, does scans and finds that actually lo and behold, they have secondary disease in the liver, but also a primary cancer in the pancreas or elsewhere. So nowadays, we do go around talking to our colleagues in the hospitals across our patch. So our patch runs all the way from Chichester to the east, to beyond Wareham and Weymouth in the west, and up far north as Basingstoke north, as well as sort of Salisbury. So we cater to a population of about 4.5 million, and we've been running a hub and spoke model for quite some time now. So I go and do a neuroendocrine clinic once a month with Mark in Bournemouth. We have our lead there is an oncologist called Mike Bain, so he runs the show along with Mark, and I come and help with that clinic once a month, so in case patients need operations, etc. And Tom Armstrong, my colleague, joins a gastroenterologist called Richard Ellis in Portsmouth once a month, and again they see those patients from that patch. And then we do get patients being sent to us from Basingstoke and Salisbury as well. So we have lots of patients, but frequently it'll be some other reason for why they get scanned and the diagnosis has been made. We do like to have biopsies, and that'll generally be either from the secondary side, but tends to be the liver, or from the primary tumor itself. And there are ways and means of doing that, normally with endoscopy, colonoscopy to take a sample, or something called endoscopic ultrasound, which is a camera that you can put down via the gullet into the stomach. This is mainly done for the pancreas, which has an ultrasound scanner at the end of it, and you can use the scanner to pinpoint where the abnormality is, and then stick a needle into it and take a sample. Very good way to do it. So how is the diagnosis confirmed? Well, mainly through scans. So most patients here who have been treated for NETs and had their diagnosis of NETs will have gone through the rigmarole of having a CT scan, an MRI scan, an octreotide or tetrachroid scan, and some of you would have gone up to London to have a gallium-68 PET as well. Along with that, we take biopsies to confirm, so we get actual cells, look at them under the microscope and confirm that this is a neuroendocrine tumor, make a determination of the grade of the tumor, and you will all remember that a lot of you will remember that you've had blood tests done where we look at a whole panel where there are sort of certain markers in the blood that are raised when someone has a secreting neuroendocrine tumor. And some of you who have liver secondary disease or have had liver secondary disease will know that you've got to wee into a bottle for sort of 24 hours, and then we test that to look at a byproduct of one of the proteins made in the liver. So there's a lot of work that goes into coming up with an assessment of the tumor itself. So this is sort of functional imaging. So this is somatostatin analog sort of imaging, and this has revolutionized what we do. So this is the tetrachroid and octreotide scan, as well as the gallium-68. So 80% or 85% of neuroendocrine tumors express the octreotide receptor, which is a specific sort of protein that sits on the surface of the tumor. So you can actually give patients octreotide, which can be labeled with a radioactive substance, inject it into the bloodstream, and it'll go and sit on wherever the tumor may be. So the really good thing, or the interesting thing about it, is that the tumor could be in the primary site, so that's in the gut or the pancreas. It could be in the secondaries, which is in the liver, and of course we do see in lymph nodes, so lymph glands, which can occur either behind the gut or in sort of other parts of the body, like the neck, as well as the bones. So the good thing about functional studies, or this gallium PET or octreotide tetrachoid scan, is that it'll show you tumors wherever they are if they express this receptor, and 80% of those will do that. The other good thing about this is that it allows us to give you treatment, which is the so-called radiation in slow motion. Again, slow motion is a word we use a lot with NETs, which is the PRRT treatment, so peptide receptor radiotherapy, which is that the octreotide is labeled with a radiation molecule, which is then injected, goes and sits on the tumors everywhere where they may be, so in bone, in the gut, etc., and then gives radiotherapy effectively over a 2 to 3 month period. And that's again a part of the vast number of tools we have to help treat this condition. So a good example here is, if you can see that circle, that's a pancreas there. Have I got a pointer on this?
Yes.
Do you know which one it is?
Point. And then the button under the power button.
Okay. There we go. Okay, good. I just didn't want to switch it off, really. Okay, so that red circle here, which I have to say has not projected well, and nor have my very funky sort of fluorescent green titles. But that's a CAT scan, a CT scan, and I tell patients, so the way we look at scans is that we've cut across the body, we're looking up the body, so this particular patient's head is behind the screen and their feet are towards us, so that's their right side, that's their left side, that's a part of their liver, that's a bit of the gallbladder that we can see, but actually the important bit here is that this is their pancreas. And again, not projected so well, but here is a tumor that when we gave the patient some dye, which is contrast, it lit up really quite brightly, which is a very characteristic feature of what a neuroendocrine tumor looks like. So that we were quite suspicious was a NET. So this patient has then gone on and had a tetrachoid scan, and you can see that's in the gallbladder, which is completely normal. You also get to see the octreotide in the kidneys, which is completely normal, so those are the kidneys there. But this particular bit here, where it's glowing, which coincides with that bit there, is showing you a neuroendocrine tumor. So this is the reason why we send patients off to go and have a tetrachoid or an octreotide scan or a gallium PET, because this is really quite an easy clincher telling us that this is a neuroendocrine tumor. And as you know, this poor patient would have been told that they potentially have a pancreas cancer, and if people read up pancreas cancer, they get very worried because the long-term prognosis for getting a pancreas cancer, even if it could be treated, is not particularly great. Whilst here, it's a completely different situation, and we tend to operate sort of based on size, and frequently for these size tumors we will sit tight, watch and wait and see how things go. And again, this patient might have been told in their local hospital by the team that has made the diagnosis that they're going to see a specialist, but they have a pancreas cancer, read up lots of things on the internet, which is a good and a bad thing, I guess, but are petrified that actually their lifespan has been cut short by quite a few years, potentially have quite a long way to go, chemotherapy, etc., and then we are there saying to them, actually, we're going to do nothing apart from do a scan in a year's time. So it is a different thing to get your head around. Similarly, this is quite a large lump, so about 6-7 centimeter lump sitting in what we call as the head of the pancreas. And this patient was not particularly young, about 78, 79 years old. And when we biopsied it, this was a grade 1 NET. So I said to this particular patient that I wasn't hugely keen on taking out the tumor because he wasn't very fit. And then we watched and waited for a couple of years, but he was adamant that he wanted it out because that was a potential that we could potentially cure him. So eventually last year, despite what I thought was the right thing, he'd had all the tests, he'd shown that he'd improved his fitness considerably over the 2 years that we were keeping an eye on things. He went on and had a sort of Whipple's operation to have this removed, and thankfully is doing extremely well. And at this stage, I'm happy to tell him that actually it isn't going to be his neuroendocrine tumor that's going to kill him. He will die of natural causes, something completely different, heart disease, whatever, but it won't be the neuroendocrine tumor. And that's, again, a concept that we find sometimes quite difficult to explain to patients, that you will die with your disease, but not because of your disease. And it's something else to think about, really. So, like I said, if you've got a NET or patients that have NETs will often experience a long delay between their symptoms when they come on and actually the correct diagnosis. And like I said, the average is somewhere between 9 and 9.5 years. And a lot of patients will talk about that they've been going to the doctor with non-specific symptoms for many years, and suddenly the penny drops. So, I'm a surgeon, and this neuroendocrine team that I work with and for was started by Neil. So our focus has always been that we would try and operate on patients. And I think, Neil, would it be right to say that when you went initially to conferences across the country and abroad, people would look at Neil and say that he was completely crazy? Because Neil was, was advocating for aggressive operating to remove visible disease. I know, because I've been in some discussions where Neil's talked at a conference and people have asked questions and said that they didn't think it was the right thing to do because they've had patients who've sat in their clinic for 15, 20 years and not much has happened to them. We know from our data, from the information that we have now over the last 10 to 15 years, that we clearly make a difference to patients by being very aggressive with their tumors. And there's good evidence emerging elsewhere that if you debulk, and by that I mean reduce the burden of disease in patients, there does appear to be a longer term benefit in how long they survive with or without symptoms or with or without disease. So saying that, it is always worthwhile to have a considered discussion with all your colleagues in our multidisciplinary team meeting. And you'll meet Dr. Cave, so she's one of our oncologists. Mike Bain is her counterpart in Bournemouth. They sit in on the MDT. We have a gastroenterologist, so Dr. Ellis, who sits in on the MDT. We have surgeons, and we have a dietitian. We have a nurse specialist. We have radiologists, including the team that that deliver the PRRT treatment. And the decision on the treatment sequence and how and what treatment we give is made in a very considered way. And sometimes the operation may not be the right thing to do. And again, the concept that I've got something, it needs to come out, I would say we don't look at it that way anymore. We do make a very considered decision. And actually, I know that quite a lot of our patients will have an operation at some point, but it might not be the first thing that happens to them. And again, it's a concept that we work quite hard to try and explain to our patients. So here's the list of things that you could have if you were diagnosed with a neuroendocrine tumor. So you could have an operation, and frequently, if it's a solitary tumor where we know that there's no other disease elsewhere, then that is the right thing to do. And a lot of our patients would have had that. So if it's a solitary tumor, wherever it may be, and there's no secondary disease, those patients will frequently, if they're fit enough, have an operation, because that has been shown that you could potentially cure your patient. So that's the first thing. But also, you could be, if you've got an active tumor that lights up on your octreotide scan or your gallium PET scan, then you might, the first thing that happens is that you get put onto the injections and get established on them. Because as you know, for those of you who've had, are having injections, there's a sort of a getting used to period that starts with a lower dose, which then increases. Mark and Emma will help you with that. You could also have treatment simply directed towards your liver, because the hormones and chemicals made by the tumors in the liver are generally the ones that cause the most symptoms. So frequently, the primary might not be operable, but the liver is, and we will still operate on the liver and remove as much disease as we can, because it'll allow the patient's symptoms to be much, much better. But you can also have things like transarterial chemoembolization, or which Brian Stedman is going to talk to you about. So you can put coils and foam into the liver around the tumors, which cuts off their blood supply, which then kills them off. You can do something called ablation, where you can put needles into the liver and heat them up to a high temperature and kill off the tumor that way. All sorts of ways. So we might simply just treat your liver. You might have what are called molecular targeted therapies. So these are drugs, some of you may be on them, called everolimus, sunitinib. These work by blocking specific parts of the tumor and stop them from growing. And then you could potentially have chemotherapy as well, which is not quite the same as standard chemotherapy, but that is, again, one of the things that can be delivered. And then there are new treatments coming on board all the time, and one of them is telotrestat, which a couple of you may well be on here. So, as I said, not the same as standard cancer. Frequently, survival is measured in many years, and that's a concept we try very hard to explain to our patients, especially with grade 1 and 2 disease. And the good thing about it is that you have time to make those decisions in terms of operating, and giving injections, giving liver-directed treatment. Treatment may entail different types of treatment across a period of time, and emphasis on disease control. Like I said, I will frequently tell patients that they will die with the disease, not because of the disease. And an operation does have a role to play, but frequently it's part of the bigger picture. So what do we look at? Well, all sorts of things, really. So when we look at treatment, so a good example, I had an 88-year-old who I did an operation on 2 or 3 weeks ago. So they have a neuroendocrine tumor of the pancreas. And actually their main problem is that this tumor has been causing blockage of their bile duct. So they've been getting intermittently jaundiced, and then when they got a stent fitted to stop the jaundice, the stent got blocked and they were coming in with repeated infections. They weren't quite fit enough to have the Whipple's procedure, because that is a big undertaking, but this is a grade 1 tumor, so I opted to do what's called a biliary reconstruction. So I made them a new join away from the tumor onto the liver. So I now know that they will never have a stent that'll get blocked, but I also know that at 87, the tumor is not the thing that's going to kill them. They will, die of something else. And so you have to make sort of sensible-ish type of decisions when you're dealing with this, because the other sort of option is that they have a sort of Whipple's procedure, which in an 87-year-old is possible, but you may well end up with potential complications, and your ability to deal with those is not the same as when you were 77 or 78 or 79. It is different. So we took a conscious decision to ensure that their quality of life was not impeded by the fact that their bile duct stent was getting blocked all the time. And I would expect now that they won't have any, issues at all. So what do we look at? Well, we look at age, we look at fitness of the patient. That's probably the most important thing. We look at the grade of the tumor. So we tend to operate on quite a lot of grade 1 and 2 disease, especially if it's in the primary, place as well as in secondary sites. Is the secondary disease appropriate for debulking? Is the disease symptomatic? Like I said, if you've got lots of liver disease, which can be causing you to have lots of carcinoid syndrome, we will still think about operating on the liver, and if the disease is asymptomatic or not. Options include all sorts of things. So you can do an operation for cure. You can do an operation to debulk the disease. You can do the transarterial embolization or chemoembolization, which is what Brian's going to talk to you about. You can give a whole load of treatments, including some patients, as some of you will be, are simply getting the injection. So we know from data that has come about over the last 5 to 7 years that the injection, which was thought to be simply to help with patient symptoms, so to block the carcinoid syndrome, we now know quite well, because there's been some good studies showing that it also has an anti-cancer effect. And we have got a few patients where there have been quite dramatic, scans where they've started having the injection and the liver tumors look like they've died off. It's not happened with everybody, but we do know that it can do. So you could...
if you don't mind, would that effect also register with, say, non-functioning tumours?
So yeah, well, so you tend to get the octreotide injections if you're positive on the scan, and generally those patients tend to have syndrome. Yeah, but if you
don't, will it have the same?
Oh yes, as long as it's positive on the scan, absolutely. Yeah, all you want is that the scan is positive. You know, the octreotide or the gallium. Yeah. Here's an example: 50-year-old lady who presented to their GP with vague symptoms, abdominal symptoms and change of bowel habit. Obviously, at this stage, no one's thinking about a NET, so they go through the standard pathway, which is that if there's a change in bowel habit, you need to examine the large bowel, because the worry at this stage is that they potentially could have a large bowel problem, such as a cancer. So they then went off and had a CT colonoscopy because they didn't quite tolerate the standard endoscopy. That led to, because it was a CAT scan, a CT scan, that showed that actually there was a mass, so a lump in the part of the blood supply sort of area of the small bowel. So this is frequently how we pick these up. So this was a small bowel neuroendocrine tumor, and they do show very typical appearances. So you can see this sort of spiculated appearance on a scan. Patient had no symptoms whatsoever, but had been reporting or complaining of a funny tummy. That, you know, they'd said, "Oh, I've always had a funny tummy. That's just me," you know, for years. So they went on to have a full set of investigations, as you know, those of you here with NETs would have had. You know, you get a CAT scan, so CT scan of the whole body. You get we look at the liver with an MRI. You get a tetrachoid scan, and these days, if we have doubts, you get sent up to London to have a gallium PET scan, because that's in our neck of the woods in south of England. That's where the galliums are done, at Guy's Hospital. You get a full set of blood tests, including, like I said, the chromogranins levels. You get a wee into a bottle for sort of 24 hours, which then goes off to London to show us some levels, and depending on which is the easiest and the safest place to take a biopsy from, which generally in metastatic, so secondary disease, tends to be the liver, you get a biopsy of the liver. So this particular individual had a positive tetrachoid scan, so they were positive for the octreotide receptor, which meant that we could start them on an injection, so that was the first treatment they got effectively, but also that the biopsy showed that they had a grade 1 neuroendocrine tumor. You can see there, so this is very typical features that you would find. So that's on a CAT scan, and that might not mean much, but if you look at scans quite a lot, you'll know that this is quite a typical feature, and you can see that there's a bit of calcification or this white fleck, which is again very typical for a neuroendocrine tumor. So that's what the scan looked like. They also had secondary disease in the liver. So that's the liver on an MRI scan. This is just after the patient has been given some dye. So those of you who've had MRIs of your liver will know you lie in the very extremely sort of claustrophobic tunnel with lots of knocking sounds, and then you get they will say to you that you will get an injection shortly into the cannula, and that's the dye. So they take pictures in sequences, and when the dye goes through, the liver lights up. So you can see that very nicely lit up liver. And the blood vessels and things that are not the liver don't light up. And when I say things that are not the liver, I mean a tumor, so an abnormality within the liver. And here, again, there's a tumor there, there's a tumor there. Also, when they had their functional study, they were found to have, so not only did the primary light up, so that's what I was showing you on the CAT scan, so you can see that shows that the octreotide scan is positive, but also that there was a bone met. So this is quite a typical picture of quite a lot of our patients. Disease in lots of different places, but again, not they don't have to be symptomatic from this. So here's someone who has had a bit of a change in bowel habit, got investigated, and then we found that there's actually more disease than was appreciated. So this is when they had their actual operation. So the bit that I was showing you, the one with the fleck of calcification, that's what we'd picked up on the scan. So here's the nodal mass. So that's the gland within the blood supply of the bowel. So you can just see that the bowel is about there. The primary tumor is actually under my hands there, but that's the lymph gland that has grown big and actually led to the actual diagnosis. So what happened at that operation? When we took 15 tumors out of the liver, we took 4 or 5 tumors out of the small bowel, and we also took, so the lining of the bowel, which is called, of the abdominal cavity, which is called peritoneum, we also took some disease out from that. So all visible disease, and this is something that Neil's been advocating for many years. So everything that you can see has been removed. They then went on, so we gave them a bit of a rest, because that's quite a big operation to have. And they then went on to have a gallium PET afterwards, which showed that there was still a little bit of liver disease left, but not very much really, and that bone disease that we had noted before. So they've gone on to have PRRT. And again, we would measure their survival in many years, and we are going to keep an eye on things. There are new developments where we're also retreating or re-challenging people with repeat PRRT after a few years. But again, the anticipation is that this patient will stay on their injections. We will keep an eye on things, and if the liver disease becomes problematic in the future, then we would again offer them the whole sequence of treatments that we can. So we've had patients who've had their 3rd or 4th operation on their liver across a 10-year, 15-year period, or their 2nd or 3rd operation on the bowel across a 10 to 18-year period. And each time we are quite confident that we're putting the clock back, if we think we can safely take the patient through that. So just very quickly, so abdominal nets or JEP nets really need a multidisciplinary approach. Because the disease tends to be so variable that every individual is different, we're really not able to give you that, this is the standard way we treat people. It really is tailored to patients individually. All patients, especially the ones with metastatic disease, which I have to say is quite a lot of our population, will get a whole host of treatment options thrown at them. And like I said, it's actually an evolving, sort of process where we tend to say to you that it's not, you are unfortunately going to be seeing us for many years to come, and most patients are under follow-up with us for, especially with metastatic disease, for 10, 15, 18 years, because we know that across all of that time, we will be, in most cases, in a position to offer patients more treatment. So you're not quite rid of us. So, again, I keep saying standard. So standard bowel cancer, what tends to happen is if you're disease-free for 5 years, you get a golden handshake, a goodbye. That's it, you're done. We don't do that with NETs because we know, A, that you can get disease coming on at some later points, but also most patients don't have that where we say to you, you're completely clear. Like I said, the concept is we'll keep you with your disease with a good quality of life for many years to come. So just very briefly, so that's the man who sort of started it off for me. I had done some neuroendocrine work before I came to Southampton, and now I'd say it's about 30 to 40% of my work now, and we are doing some very interesting and sort of innovative work with it. We're probably the biggest surgical neuroendocrine practice in the country. The Royal Free have a very good a very big medical net practice, and I'd say that we're the biggest surgical practice in the country, and that's really mainly down to Neil. It's a shame it's not really projected that much because Neil's basically splattered with blood on his visor. And that was sort of the way he liked to operate, really, that it was always a bit like that. I can't really say that our success is not due to the fact that we have some amazing specialist nurses. So that's Mark, and that sort of sums up Mark, I think. But also, I have to say, I can't see why the doctors haven't been given one of these, Joe. So I spent most of the NET clinic on Wednesday last week telling Mark that it was grossly unfair that I didn't have one of these. So excellent. So that's Mark, and there's Emma and Rachel and Emma. And honestly, our service cannot really work without these people. They are the linchpin of what we do. And I think it really is quite important that we make sure that everyone knows that. That's John Knight, so he's our bowel specialist. So whilst Tom, who's standing right at the back there with the IORT machine, that's another one of our colleagues, he's Ali Arshad, so he's leading our robot work at the moment. So now we've started doing sort of robotic pancreas cancer operations, and Ali's the lead in that. It just goes without saying that this really is not possible. It's a really heterogeneous tumor, which means it behaves in all sorts of different ways, but that also means that you need a whole team of people to deal with. And actually, I didn't get a picture of Ruth, and I'd completely forgotten that I had to take a picture of her, but I am glad that she's actually giving you a talk, so she'll be standing here for about an hour, so it's absolutely fine. You'll see, you'll know exactly who that is. I'm very happy to take questions. Thank you.
Does anybody have any questions at all?
I'd be interested to know what percentage of patients develop a higher grade.
Oh, you mean from diagnosis that moves on?
Yes, so we move from 1 to 2.
Yeah, so it's a known phenomenon. You know, we know that, and generally we work that out because if we find someone who has a grade 1 tumor and we're sort of following them up, and most people with metastatic disease will get scans on a yearly basis. So and the whole point of that is you're trying to look and see whether they have progression. And if the subsequent scans end up showing that there's more disease than was anticipated, then frequently we will have a rethink. And it's a process called de-differentiation, where the tumors do change in the way they behave. And I'd say, I don't think we've looked at that, but I'd say it's in the tens or even less than 10%. But it is a question that comes up time and time again in MDT, where we think about rebiopsying or rescanning or redoing a gallium because we have concern that the tumor has changed grade.
We did do some research on it about 8-10 years ago.
Okay.
And I think out of all of the tumour specimens that we had, where we could look at a primary and look at a secondary, it was about 8 to 10% of secondary tumours that de-differentiated from a grade 1 to or a grade 2 to a higher percentage, or significantly higher percentage.
Yeah.
Not always gone across a grade boundary, but secondaries are often more aggressive than the primary, but by no means always. If that makes sense.
I just wondered if it would ever work the other way around.
I'm not sure it does, actually. So if it stays as, mostly they'll stay with the grade they're at. It's unusual.
Any other questions?
Exactly how much do you want that hoodie?
A lot. Yes.
I hear you. Thank you very much for our appreciation. Thanks, Arjun.